crash cart very regularly, and you said that already, took the words out of my mouth. Thank you.
Thank you so much.
The next session on stage is on fetal growth restriction, and here the lead discussant is Dr. Elizabeth Jacob. Along with that, Dr. Nushat Aziz from Hyderabad and Dr. Uma Ram from Chennai. And to this dream team comes our new faculty of today, Dr. Bijoy Balakrishnan from Simar. Bijoy needs no introduction. He is a gynecologist, he is a fetal medicine specialist, he is a radiologist, all rolled into one, and if you ask me, he is a very good friend of obstetricians. Over to Elizabeth Madam for this session of fetal growth restriction.
Very warm good morning to one and all. Defining, diagnosing and managing fetal growth restriction remains and continues to remain an enigmatic puzzle. And in the next 30 minutes, by discussing two case scenarios through our esteemed panel, we'll try to decipher the smallness puzzle to you. And finally, hopefully crack the Pandora's box on fetal growth restriction. Going directly to the case, hope the panelists are all set. Okay. So now we have a 25-year-old second graviда with a previous abortion with regular cycles. She had her antenatal checkup at a peripheral hospital. Her NT and anomaly scans were normal. She came to us at 31 weeks and 2 days with a blood pressure of 150/100 with no impending signs. Her initial gestational hypertension profile was normal. She was started on labetalol 100 milligram BD. She did have a growth scan done at her center at 28 weeks. Now, this was the report. Let's kickstart with our fetal medicine expert. Is there more to it than meets the eye from this report?
Before I start, I just want to say that the previous session, the acting by Paili sir and his team was amazing, and that deserved a little bit of applause. I've never seen such amazing acting from professional doctors, and it was absolutely amazing, and it brought out the message really well. Now, coming to this, the first thing when we look at a scan, especially when it's a growth scan, I will not try to interpret it without a growth chart. So if I see an image like this with weeks and numbers, it makes no sense to me. Okay. I would want to see a chart.
Okay.
Okay. So now yes. Yeah. So now when I get a chart, immediately I know that this baby is falling off the chart. You can see that all the measurements are sort of plateauing, and you can find that the second dots are all below the red line, which immediately tells me that this baby is extremely small. So when I see a baby that is extremely small, my next question is, why is this baby small?
Exactly.
So my eyes go down to the umbilical artery, and I can see that the pressure in the umbilical artery, the umbilical artery is high, it's above the 95th centile, which tells me that there is a problem with the umbilical artery. The resistance is high, telling me that probably the placenta is damaged.
Yes.
And if I drag my eye downwards to the MCA, I can see that it's at the 5th centile, which tells me that this baby is hypoxic.
Absolutely.
So immediately I know that this baby is abnormal small.
Oh, yes.
It is not constitutionally small, it's abnormal small.
Yes.
So
this was a scan which was done again at 31 weeks when she came to us, and we have extrapolated the growth findings at 28 weeks to just denote to you at 28 weeks of her AC at that time was on the 5th centile, and definitely this baby should have been put on the radar. Now at 31 weeks with this finding, how relevant do you think the different growth charts are to us? Uma ma'am, can you tell us about the different growth charts that are available, and then what should be practically we convey to our audience here?
Yeah, I think, we could have an entire session on growth charts, but for the purpose of this discussion, I think it's important that we use a standardized chart, and we use that consistently on the baby and in all our women. So you can't have the first growth plotted on something else and the second on something else. So let's just stick to one chart and use it.
Yes.
Most machines do not have a standardized chart incorporated into them. Therefore, you need to have a software which will generate a growth chart on a standardized chart.
Absolutely.
So whether I think the world is divided into those who use customized charts and those who don't, and that's, like I said, beyond the scope of this
so for
conversation.
all practical purposes,
but you use the same chart, you use a chart and you use it consistently.
Absolutely, ma'am. So this patient, like Dr. Bijoy had said, the umbilical artery PI was raised with a EFW which was second centile. Bijoy, are you happy with the kind of growth restriction definitions and interpretation, how they have interpreted this chart in this report? Or
So
how would you like to report fetal growth restriction?
Yeah, so Bijoy, basically I think we want to comment on the fact that this report just says that there's a single gestation corresponding to 27 weeks and 4 days, right? Without indicating what centile, what is happening. So is this enough information as an obstetrician for me to act on? Or is there an interpretation of this baby that needs to come with the report?
No, you can actually say that this baby is growth restricting early. So
Yes.
in the report, it would be better to add that the estimated fetal weight is at such a centile, along with an abnormality in the umbilical artery. So we are looking at early onset fetal growth restriction, and we do stage them according to their severity, and you could probably call it as maybe stage 1 FGR, because you can see there is diastolic flow within the umbilical artery. So when you classify it into stages, it immediately gives us an idea as how long we have and on how we can counsel this patient, how frequently we need to call them up for follow-up. So all those questions can be easily answered.
Yes. So basically, what should be our approach to diagnosis? Firstly, to confirming the dates. Secondly, to confirming the smallness. And finally, to confirming the growth restriction. So specifically for our patient, the dating was not an issue because she had regular cycles. She had an NT scan in the beginning. The smallness also was dictated by the EFW and the growth chart. And finally, the Dopplers had sealed the diagnosis. Dr. Bijoy, there are some cases in which we find that the EFW is within the normal range, but you find the AC alone being less than the 10th centile. Is it clinically relevant, and does it tell us something about the baby?
The first thing I want to mention is about the dating thing.
Yes.
Although yes, in this you have the CRL, but what I do see most of the times is that you have a first trimester scan which does not actually document the CRL. Now, in this case, we already know there is FGR, but it's always important to document the CRL because we need to know the gestational age even in this case, because unless we know the gestational age, we will not know when to time the delivery. So that's one point. Second thing about whether AC is better than estimated fetal weight. Now, if you look at estimated fetal weight, it is the combination of BPD, HC, AC, and FL. It looks at multiple parameters. AC actually is the best predictor of fetal weight because it is the only parameter that takes into account subcutaneous fat. All the other parameters, BPD, HC, and FL, are based on bony landmarks. So it does not take into account the fat around the fetus. Therefore, AC is a good predictor, but as a single predictor, it does not work that well.
Yes.
You have to look at the estimated fetal weight. Now, there are conditions where you can just have a small abdominal circumference, but a normal EFW.
Yes.
And that happens, especially nowadays, it's a little bit more frequent, where you find shunts within the liver, which leads to a smaller abdominal circumference. And we have found that increasingly common post-COVID, where women have had a history of COVID, and we find there are shunts developing in the third trimester, leading to a small AC. And the management is different in those cases. So I would say, if you want to call FGR, look at the estimated fetal weight. But if you find isolated smallness in AC, look at the liver vasculature a little bit more closely.
Can I add in, Bijoy? I think what we need to convey across is if the AC is below the 10th centile, follow this baby.
Yes.
Okay,
Keep her
that's
under
very important.
surveillance.
Just don't leave the baby off because it might be a first predictor.
Nusrat ma'am, we have this consensus-based definition for early and late onset FGR based on the Delphi consensus with the solitary and the contributory parameters. Can you simplify this for our audience so that they'll be able to incorporate it into their daily routine practice?
Simplifying it is less than 32 weeks and more than 32 weeks, very important. We don't have much of problems in identifying early growth restriction. We have a lot of problem in identifying late onset fetal growth restriction. That's another one.
Yes.
These definitions should be put up on the chart so that, we go ahead and see, what am I looking at? Is the estimated fetal weight less than the third centile? If it's so, directly under FGR. If there is any kind of uterine artery Doppler abnormality or umbilical artery or any Doppler abnormality, it's FGR. But if you don't have, then you go across to a contributory factors that is plus, plus, plus. Now, if you keep this on the chart, it's always much better that if you have 8th centile baby, but you have an uterine artery Doppler which is abnormal, then I'm going to call it FGR. So that's all it means. It doesn't mean much. Between 3rd centile or 4th centile to 10th centile, you need to add in another parameter, whereas anything above will be single factor. That's
Yes.
easy to say.
I just want to add one point on early and late FGR. Most of us use the gestational age as the cutoff, but I want you to understand that it's like, if suppose a woman went to bed at 31 weeks, 6 days, and next day morning she got a scan, so she does not become automatically late onset FGR.
Yes.
Time constraints have been artificially created by us to act as a surrogate to understand the disease. So the 32 weeks is just a surrogate marker for us to understand what's happening in early and late. In early, the placenta is very bad, and therefore the baby growth restricts early. And therefore you're going to have a very bad umbilical artery because the placenta is really bad, and therefore over a period of time the baby's heart is going to fail. In late onset growth restriction, you have a mild form of placental disease, and therefore the baby will go comfortably well till around 32 weeks or even later, and after that it's going to feel the pinch of less nutrition and it's going to growth restrict. So in that baby, there isn't going to be cardiovascular compensation. You are not going to get DV abnormalities or severe abnormalities on the umbilical artery. You're going to get hypoxia, which in turn will suppress the brainstem and lead to fetal demise. So when we say early, we are saying that this baby has growth restricted early, has severe placental disease, so look at the DV. When we are saying late, we say that there is a mild placental disease, the umbilical artery is normal, the DV will continue to be normal, so we need to look at signs of hypoxia, which is basically the brainstem. So early onset growth restriction is very obvious because it stares at you in the face, a small baby with an abnormal umbilical artery. Late onset FGR, the problem is we don't do a scan routinely in the 3rd trimester. You're only going to do a clinical assessment, and on doing your clinical assessment, you can miss out on late onset FGR because this baby will have near normal LICA, will be reasonably growing well, and therefore you might not be able to pick it up on your clinical examination unless you do an ultrasound. And when you do an ultrasound, you will find that the baby is small, but all the Dopplers are normal because the placenta is not that bad. But this baby has hypoxia. And because of hypoxia, this baby is going to have a brainstem suppression, which will be only picked up on your CTG or your biophysical profile. I think that is the distinction between early and late.
Absolutely. Only Dr. Bijoy can explain it so simplify it so well, that tussle between the heart and the brain. Of course, she was in stage 1 FGR in the Barcelona staging, and I think we already discussed that this should be the norm and this should be put into our clinical practice. So here we had an early onset fetal growth restriction at stage 1 at 31 weeks. She was admitted. Her initial NST on admission was normal. A maternal surveillance for preeclampsia was normal. A daily fetal movement kick count chart was kept. A daily NST was planned. An ultrasound Doppler weekly and a twice weekly biophysical profile was planned. And the growth was to be assessed every 2 weekly. A neonatology counseling was to be done. Nusrat ma'am, in the setting of preeclampsia, will that be the defining point of monitoring, and will that be a game changer for this particular patient?
Whenever you have fetal growth restriction alone without any maternal disease, then all the plants hold very nicely, and you can follow it up as the Barcelona calculator would say, call them after a week or call them twice weekly. But whenever you have as volatile disease as preeclampsia, that determines how the baby is going to go. You never know what's going to be in hold for us tomorrow. So when we admit a woman for preeclampsia and its monitoring, we do put in a surveillance plan which includes an NST daily, early in the morning. So, and these monitoring will continue maybe a little later in the day. So that's what we have been holding. If you have acute hypertension, if you have any of the parameters going bad, mother's becoming sick, baby will become sick, much more sicker. Sometimes when we control BP also to a great extent, then you may have an insult on the placental circulation also and have a finding.
Okay. So, Uma ma'am, would you like to do any workup on this patient, early onset fetal growth restriction with preeclampsia in this setting? Or in which ideal patients would you like to do a workup, and what tests would you actually prefer to do?
So, obviously, in this setting, you would work up the mother for preeclampsia in terms of acute management. And even if her blood pressure comes under control, we still need to keep a watch on the baby. And so our triggers are going to be both the mother's hypertension and the baby getting unwell. Now, if you're asking about which growth restricted fetus would we work up, I think, if you see a fetus that is growth restricting fairly early on in pregnancy with normal Dopplers and Leica, suggesting that there isn't placental dysfunction that is the cause, then you have to look for other reasons, which could be infection, which could be structural abnormalities, which could be chromosomal abnormalities. And so, which is why it's important to actually plot growth even at the time of your target scan and see where this baby is falling. Look at the uterine artery Doppler at the time of the target scan. So if you go back to this case at the, no, you don't have to move back, but I'm just saying 28 weeks when you saw a fetus on the 5th centile, if a Doppler had been done at that point, then we would have raised, maybe her hypertension would have also been picked up before she came with that acute crisis, right?
Yes.
And therefore, now going back right to the beginning, I think all of us as obstetricians need to screen for preeclampsia in the first trimester. As a matter of routine practice, we are all screening for aneuploidy, but preeclampsia is a far more common disease. And if you're going to do a combined screening, it makes perfect sense to screen because that group of women who have placental dysfunction from resulting in preeclampsia, who are also likely to have growth restriction, would be benefited by initiation of aspirin. So I think that is some message, strong message that we need to send out.
Okay. 2 days later, she complained of reduced fetal movement. Her maternal surveillance was still continuing to be normal. Her NST was also reactive. But an ultrasound which was done at that time showed an umbilical artery with an absent end-diastolic flow. Her DB was normal. Her AFI was 5.5. There were fetal breathing movements seen, and the biophysical was 8/10. So now this patient had moved fastly into stage 2, absent end-diastolic flow, stage 2 FGR. Now, how will you monitor her now, Dr. Bijoy?
What is her weight? What is the baby's weight?
The weight was 1.8 kg, ma'am.
Okay.
No, this baby was 1.05 kg, ma'am.
One point about the Barcelona protocol, which all of us are aware of and most of us are following, you should understand that it is the bare minimum. It is just a guideline as to the bare minimum that you should do. It is not the standard of care. So for example, if you have a mother with preeclampsia and if you have stage 1 FGR, the Barcelona protocol says that you need to see them only after a week. But once you know that the mother has preeclampsia, you know that this baby is going to deteriorate very fast, and therefore you will increase your surveillance. You will have to at least see them maybe once in 2 days or 3 days. And remember that you have to also look at the CTG and the biophysical profile. Because all the trials that have looked and shown that there is an efficient use for Doppler, it has only worked in a setting where the CTG and biophysical profile were available almost on a daily basis. Okay. So that's why in your scan, even though the umbilical artery has deteriorated and shows absent end-diastolic flow, I'm happy that the breathing movement is seen and you have a good score of 8/10. And whenever your radiologist complains that they cannot do the entire biophysical profile, because technically the biophysical profile needs about 20 to 30 minutes to complete, because you need to look at all these parameters. So a simple thing you can ask your radiologist or sonologist to do is to check for the breathing movement, because it is the first thing to go off in the sequence of events. So if the breathing movement is present, you don't have to look at the movement, fetal movement or tone. Automatically you know that they are going to be present. So just ask them to look for the breathing movement while they do the scan. And a biometry scan should take around 5 minutes. So within that 5 to 10 minutes, if you don't see the breathing movement, tell them not to waste time and send the patient for a CTG. Because on the CTG, if you see that the CTG is reactive, again, automatically you know this baby does not have hypoxia and the score is going to be good. So do not refrain from asking, if the radiologist puts in a protest of they can't do a biophysical profile, they are overloaded with work, tell them to just look for the breathing movement while they complete the biometry scan. Okay. So now coming back to this case, You have absent end diastolic
Absent
flow.
end diastolic
You have got
flow.
a good biophysical profile, a good
Yes.
CTG, and your
Yes.
gestational age would be around
31 weeks and
31 weeks. So we can still wait. We
Yes.
can still wait, and understanding that this mother has preeclampsia, we will increase her surveillance, and we will probably see this baby almost on a daily basis.
Okay. So in our practical setup, what should be the safety net? What are the things that we need to take care and decide what are the absolute indications for delivery for this particular patient?
So, I mean, if you look at the studies that show CTG safety net, they're all done on computerized CTG, which we
Yes.
don't have.
Yes.
So I think we need to, but that doesn't mean we don't do a CTG. I think if you see a baby that's happy, that's accelerating, good variability, that baby is not hypoxic, and therefore you can wait. But if you see spontaneous decelerations, if you see loss of variability in a baby that's growth restricted, then that would be a criteria to bail out. And therefore, I think we need to use the combination. A lot of us have started to rely a lot on the Doppler when we are monitoring, and a lot of fetal medicine centers actually don't do a CTG. They just do the Doppler and send the baby back to us. And we have stopped looking at the CTG, and I think therefore we are very lulled by the fact that our neonatal units can handle smaller and smaller babies. The whole rationale to look at the DV and wait is not because we don't know that the baby is hypoxic when there's absent end diastolic flow, but because gestational age is the second strongest criteria that that leads to outcome besides Doppler abnormality. That's the reason we push to see a DV change before we deliver a baby before 32 weeks. Therefore, it's important. So I think to apply in our clinical practice, we may have to do a CTG even twice a day.
Yes.
Practically, if you're a small time, place, you don't have an in-house person who can do the Doppler. Ideally, if you're dealing with preterm early IUGR, you should actually refer this baby in-house to a team which can monitor, because somebody else doing a Doppler, somebody else doing a CTG, two different people looking at this baby is not the ideal way in which you would manage an early onset growth restriction.
And I just want to mention about the delivery cutoffs when you're taking. One important point is that after the Barcelona protocol has come in, you would find that most neonatologists are not happy. Most of them would say that, why are you waiting so late? Because we find that most obstetricians are stuck up on the protocol and waiting for the DV to reverse and not looking at the other parameters which are telling that this baby is becoming bad. So the protocol will work only if you use the CTG and the biophysical profile, or else you will be giving an asphyxiated baby into the NICU.
So
Very important, because there was a time when you don't have a computerized CTG, and then the CTG just moved out. But the FIGO guideline has brought it back inside, so anyone who wishes to revise their fetal growth restriction guidelines, they have given low resource setting as to what needs to be done, and I think it's a very important point that Bijoy is making, that CTG needs to come back, especially in late onset fetal growth restriction.
So steroids were given, definitely steroids were indicated in this patient. Maternal surveillance was continued, a daily monitoring with Doppler and a daily NST was done. So next day she again complained of reduced fetal movement, and this was the NST graph. Of course, now there is unprovoked spontaneous decelerations. She has moved on from stage to FGR with a safety net crossed. Now what would be the mode and timing of delivery? Is there a role for MACSELF, and how will you counsel the couple?
I think I would have steroided this baby at the point where there was absent end diastolic flow, because the mother also has preeclampsia.
Yes.
If there was no preeclampsia, then you know that you may gain time, and even if you see a DV abnormality, you can get that 48 hours if the baby is well. But in a mother with preeclampsia who's not perceiving fetal movements, I would worry, and definitely that trace need not even have gone on for that long, actually. And so there's no time for magnesium sulfate here.
Yes.
Because this baby needs to come out. You're not going to wait on MACSELF on this baby. But yes, in the context of prematurity and neuroprotection, if you had the luxury of time, you would give till 32
So she
weeks.
underwent an emergency LSES, a male baby weighing 960 gram with a cord pH of 7.1 with lactic acidosis was delivered. The baby was ventilated, now stable at 1.01 kg. Nusrat ma'am, will you send the placenta for histopathological examination?
all babies, all those who have preeclampsia also should be sent, but all the babies which have fetal growth restriction should be sent. Very importantly, we want to find out whether it's a maternal vascular or what is it that I'm looking at.
Yes.
But important, there are 2 or 3 lesions of the placenta that have a recurrence rates, so it helps you in counseling, you know, what am I going to do next time.
Okay. This patient had gone through a tumultuous period and a baby was sick in the NICU. So she asked us, why did it happen to me? Was it preventable and will it recur in my next pregnancy? So, Nusrat ma'am, can we predict FGR and how do we risk stratify fetal growth restriction?
The first trimester screening does definitely have the prediction which is available. Moving across to the recurrence risk, which we have, then if it's severe preeclampsia, then preeclampsia has a recurrence risk. Fetal growth restriction, if I have a placental histopathology, then we can predict 25%, 10%, or some of the lesions like maternal floor infarction or perivillous fibrin deposition. These have a very high recurrence rates.
Okay.
That might be, the FIGO has given a recurrence rates for, you know, some of the placental lesions, and it's very nice to read that.
Okay.
Provided we
Fast
get
move on to the
placental
next case scenario for want of time. The second scenario was a second gravida with a book case. NT anomaly scans were normal. The growth scan at 29 weeks was normal. She came to us at 35 weeks complaining of reduced fetal movement. We did an NST for her, which was reactive. She did perceive fetal movement. Dr. Bijoy, will you admit her? Will you do an ultrasound? And how many of us here would have done an ultrasound after 29 weeks if she had not come with a reduced fetal movement?
You're asking a person who sells cakes if he has a pastry shop. So it is obvious that I will do an ultrasound.
Yes.
And I always believe that you need to do ultrasound to pick up a growth restriction. The severe ones are the ones that only you can pick up. And in this case, yes, definitely. In an unindicated case, I would not do an ultrasound at 29 weeks for a low-risk woman. But otherwise, definitely, I would want to do an ultrasound in the 3rd trimester, somewhere around 32 weeks.
Okay, the
and I would follow
ultrasound
it
that
up.
was done now showed an estimated fetal weight which was 8th centile and an MCA which was 2nd centile. Now, what is your diagnosis and how important do you think that the fall in the centiles from the 29 weeks to the 35 weeks is significant for this patient?
Whenever you have falling centiles, now the consensus is that if you have a fall in centiles by 2 quartiles, then it is significant. But having said that, that is just a consensus. Whenever I see that the growth is falling, I always look at the Dopplers and see if there is any sign of hypoxia. And I do call them back for a growth scan again, just to be sure that this baby does not fall off the chart further down her pregnancy. So yes, you have to look at falling centiles.
So here now we have a patient with late onset fetal growth restriction. We would monitor this patient weekly with an umbilical artery MCA CPR, a twice weekly NST and a biophysical profile. Now, what is the role for CPR and MC? And with this patient having an MCA at 2nd centile, are we indicated to rush in to deliver this baby now?
The common error that we have right now, at least across most parts of Kerala right now, is reports are coming with the CPR and MCA, and most of them are highlighted, saying MCA less than the 2nd centile, severe hypoxia, deliver, and stuff like that. Please be very clear. An abnormal CPR has got a high sensitivity, but it also has a very high false positive rate. So we cannot rely on CPR as a predictor for delivery. But if you find that the CPR is abnormal, the thing that we should do is increase our surveillance. And increase our surveillance by using the CTG and the biophysical profile. The CPR never is a trigger for delivery before 37 weeks. Now, after 37 weeks, if you find that the CPR is very low, and if you have to do a lot of surveillance just to be sure that this baby reaches 38 weeks or 39 weeks, then it doesn't make sense. And that's why maybe after 37 weeks, if you have a low CPR and you're forced to do a lot of surveillance to push this pregnancy beyond 38 or 39 weeks, I would suggest to go in for delivery. But before 37 weeks, definitely it's not a trigger.
Elizabeth, I just want to make 2 points.
Yes,
One is if any Doppler abnormality that is picked up has to be reproducible. And this is incorporated into your Barcelona protocol also. So CPR, particularly in the 3rd trimester, when the head is down, even the pressure of the probe can increase, change what is happening. So it's very important that you get a reproducible Doppler abnormality, because it's going to trigger an intervention resulting in delivery. And quickly, the timing of the scan, if I think to discuss what Nusrat said about growth risk stratification, we need to do that at booking. We need to do that at the time of the target scan. See if this woman has risk factors for early growth restriction. If she does, 28 weeks may make sense. If she doesn't, then 36 weeks is a better point in time to pick up late growth restriction. And because otherwise our resources are going to be overwhelmed. If the resources are not overwhelmed, then you're okay to do 2 scans in this.
So definitely the trigger for delivery should be the CTG and the biophysical profile, or deliver them at term. So here we went ahead and we planned for a delivery at 37 weeks, having monitored her and delivered a female baby weighing 2.01 kg. So will doing a routine growth scan at 36 weeks be the solution for the diagnostic puzzle of late onset FGR? In one sentence, please.
Who's going to talk?
Because it's one sentence, I'll say yes, it is. Do it at 36 weeks if you want to pick up growth. But I will also suggest, because I sell cakes and I own a pastry shop, do it at 32 weeks also to pick up late onset anomalies. So you can prepare the couple for any anomaly that is present, so that the peripartum care is excellent. And it gives them time to get their resources ready. It could be anything. It could be a congenital heart disease that has a late onset, or ventriculomegaly that sets in late. It gives them time and resources to be ready for it. And 36 weeks, definitely, if you want to prevent unexplained demise that happens for the missed late onset FGR.
Okay. I'll just sum up with the key messages. Confirming dates in the first trimester is the alpha, or the beginning in the approach for diagnosis of FGR. Always plot on a growth chart. It will be your first opportunity to not miss smallness. Growth velocities with falling centiles are pointers for fetal growth restriction. Dopplers will validate the diagnosis for FGR. Use clear and concise definitions for early and late depending on the Delphi consensus. The early and late go much beyond the arbitrary 32 weeks cutoff. The Barcelona staging, don't use it as a blind man's forte. Look into the maternal and fetal conditions. Never miss out on the absolute delivery endpoints. And except for stage 1 FGR rest, all deliver by CS, and keep a low threshold for CS, and better to avoid the prostaglandin. CPR, do not use it by itself for a trigger for delivery. NST and biophysical profile should be the triggers. Risk stratification should be done, and a routine scan at 36 weeks may be the puzzle solver for late onset FGR. I leave you with the food for thought that Dopplers are not the panacea for fetal growth restriction. Kindly listen to the mother and the fetus. The crossroads between the obstetrician and the neonatologist exists for the early onset. So balance the iatrogenic prematurity versus the stillbirth. The late onset FGRs are the underdiagnosed and the overrated. Then, of course, there is a subset of SGAs, which may be the hidden FGRs. Be the alert detective like the Sherlock Holmes. And definitely initiate a program in your institution based on the birth centiles to audit your SDA detection rate. Thanks, a big thanks to my esteemed panel, and a big thanks to you for giving me that extra minute. An IUGR baby may look tiny and fragile, but don't estimate the courage, strength, and determination of the baby born too small. Thank you, thanks a lot.
Thank you, Elizabeth Madam, and to the wonderful team. It was a great session. Thank you so much. Please join for the photo session.